Isoniazid preventive therapy. Well, you know the classification of childhood TB. What is class 1 in TB exposure, class 2 TB infection, class 3 is TB disease, class 4 is TB inactive. And of course, we know when we have class 3 or TB disease, a child should have at least 3 or more of the following criteria: exposure, a positive tuberculin test, signs and symptoms suggestive of TB, meaning prolonged cough of 2 weeks or more, prolonged fever, maybe 2 weeks or more. These are the things that correlate directly with primary pulmonary tuberculosis, or inability to recover from a very simple illness. And of course, chest x-ray suggestive of tuberculosis, and the laboratory findings which were discussed a while ago already. In terms of class 1, class 2, and maybe class 4 are usually asymptomatic. They don't have the TB disease. And the WHO guidance on the national TB program of our government in the management of TB in children, as discussed, as mentioned by Dr. Telly Howe, this is recommendation 21, that children less than 5 years of age who are household or close contacts of people with TB and who, after an appropriate clinical evaluation, are found not to have active TB. Meaning, ginawa muna natin ang diagnostics. And at the end, the verdict is, no, not tuberculosis. Then, in those patients, we should give 6 months of Isoniazid, a maximum dose of 300 milligrams per day. This is a strong recommendation and high quality of evidence. Why IPT? Well, because the risk to develop active TB following infection is high, and the age has something to do with that. And of course, the other thing is the immune status of the child. Well, you remember, I'm sure, Dr. Ben Murray, a TB expert, was one of our plenary speakers sometime in the past, I think 3 years ago. And he had a lot of work on tuberculosis. In fact, he had recent writings on the natural history. He went back and dated from the pre-chemotherapy on TB of how it presents, together with Dr. Gee and Dr. Scaff. For those of us who are on collaborators in tuberculosis TB in children. And he mentioned there that the progress to active TB usually occurs within 12 months of primary infection, such that we know that if there is a new diagnosed primary pulmonary TB in the family, then transmission is recent and transmission is ongoing. Such that in this slide, well, it says here, the age-specific risk to progress to disease following primary infection with MTB in immunocompetent children. If the age is less than 1, no disease in about 50%, but pulmonary disease in 30 to 40%, and dissemination in about 10 to 20%. And as you go down, of course, it lessens somehow, but again, the possibility is still there. Well, Dr. Telly Howe also mentioned about the symptom-based screening approach to child contact management. And again, Isoniazid preventive therapy, we use 10 milligram per kilo for 6 months. And these are for children of less than 5 years of age who are household contacts of a bacteriologically confirmed TB case, regardless of the skin testing, or a clinically diagnosed TB case if the child has a positive tuberculin skin test. The other indication is on persons living with HIV with no signs and symptoms of TB, regardless of age as well. So, in this Isoniazid preventive therapy, which is also part of our manual of procedures of our national TB program of our Department of Health, we have to properly document it and use the treatment card, IPT card, and register the child in a Form 9 IPT register. Likewise, we have to monitor and assess the child at least every 2 months, better still, monthly, and document the weight, the symptomatology, adjust the dose of the INH according to weight. And if there are signs and symptoms referable to tuberculosis, then you have to treat it as TB disease. So in that case, the IPT, or the preventive therapy, is a failure. Well, these are the outcome of the IPT. Completed IPT, that is, the child was able to complete the 6-month regimen and remains well and asymptomatic during the entire period. Or lost to follow-up, meaning the patient had interrupted the IPT treatment for 2 consecutive months or more. Or the patient died. A child who dies for any reason, not necessarily because of tuberculosis, during the course of treatment. Failed, a child who develops TB disease during the course of therapy and not evaluated. These are patients who transferred residences, even if they're properly documented in their transfer, but whose outcome is not known, then that is not evaluated. Okay? So these are the guidelines for TB prophylaxis. Okay? Well, just to let you know that totally it's 6 months therapy. Well, regarding the latent TB infection is class 2, okay? And IPT is also treatment in terms of latent TB infection. And the WHO guidelines, the 2014, as well as the Manual of Procedure of our NTP says 6 months of INH. So we are trying our best to harmonize these recommendations. However, in terms of the American Thoracic Society, the CDC, and the American Academy of Pediatrics still recommends 9 months of INH. However, in the Cochrane Review of 2010, the INH for preventing TB in non-HIV infected persons, which was authored by Drs. Ismiha, and et al., and mentioned very well prominently in the 2014 guidance, national guide, WHO guidance for the national tuberculosis program, says that the 6-month INH therapy versus 12 months is almost the same, and the difference is not statistically significant. I did not present anymore here the forest plots and all the recommendations. Suffices to say that at the end, the difference is not statistically significant. And I think this is the reason why no less than our country is following the 6-month therapy. In the latest journal, December 2015, of the Journal of the International Union Against Tuberculosis and Lung Diseases, where other countries, from high-risk countries like India, Nigeria, Pakistan, shared their own experience. They are all following the WHO of the 6 months therapy for prevention against tuberculosis. Well, there are other recommendations that were mentioned in the book Evidence-Based Infectious Diseases, like a 2-month regimen of rifampicin plus pyrazinamide. However, they mentioned that this should not be considered if the risks justify the benefits. However, there's a beautiful ICT on INH plus rifapentine that is given weekly, but for 3 months only. This came out of the JAMA Pediatrics 2015, March 2015 issue, and authored by Dr. Villarino et al., where it mentioned about 29 study sites in the US, Canada, Brazil, Hong Kong, that is for China, and Spain, which ran from June 2001 to December 2010, with a good 1,058 patients, and these patients were ages 2 to 17. And the results that, of course, the completion rate was much better with the shorter one, the INH plus rifapentine, and 81% for the 9-month INH. And overall, this regimen satisfied the non-inferior criterion, meaning INH plus rifapentine is as good as 9 months. In fact, I think it is even better. Why? Because there was no breakthrough in the short duration compared with 3 cases who developed TB in the 9-month therapy. And generally, it is safe and effective. So we're looking forward to this. In fact, Dr. Ben Murray reacted and made the editorial on this, that the 12-dose drug regimen now also is an option for preventing TB in children and adolescents. However, Dr. Philip Fisher, a professor of pediatrics from Mayo Clinic, said, but a key to effectiveness of TB therapy is adherence. So real-world treatments will have to be implemented carefully. Because a lot of mothers or a lot of those who go for 9 months would say, how come? Okay naman po ang baby ko. 9 months and treatment. And so these are the limitations of such. That's the reason why there are breakthrough in terms of not completing and so on. So in terms of review of the clinical trials, the shorter it seems, the better. And so we are looking forward to those. So IPT is recommended for better adherence, and 6 months of INH is being pushed forward. Cost-benefit analysis of shorter regimens are needed, and all of you there are challenged to do such. Isang magandang hapon po sa inyong lahat.